Thank you, Harsh Bhai and Ankur sir for the kind introduction, and sorry to disappoint you regarding the topic selection. That was beyond my hands. So today I'm going to speak on the much talked about but less cared about kind of entity when it comes to the metabolic syndrome point of view. So MASLD, we all know the terminology, that metabolic dysfunction associated steatotic liver disease. So this presentation is going to speak about how we should not ignore this important entity in the spectrum of the metabolic syndrome, why we should cater to this particular indication, not only the glycemia. We have talked about the diabetes-related kidney disease, diabetes-related heart failure, and diabetes-related atherosclerotic cardiovascular disease. But the pre-runner of all these complications, which increases these chances of the CKD and CVD by 2 to 10-fold, it is the MASLD or the inflammation in the liver, which we are missing to treat, because we have a limited availability of the molecules which are available to be approved for the treatment of this particular entity. This is going to be the outline of current presentation. So first of all, let's just briefly know about the change in terminology. We all are aware about the terminology NAFLD and NASH, non-alcoholic steatohepatitis and non-alcoholic fatty liver disease. Just recently, maybe for a few years back, the international speakers or the international authorities, they suggested a change in terminology to MASLD and MAS from NAFLD and NASH. So why this change in terminology? First of all, because metabolic dysfunction associated steatotic liver disease, it encompasses all the spectrum of liver disease, right from steatitis, that is the fatty liver steatosis, to inflammation steatohepatitis, and it also avoids the derogatory or the kind of stigma associated with the term non-alcoholic. Maybe non-alcoholic can be a stigma for some, can be alcoholic can be a stigma for some. So it is variable, but this is the change in terminology. The prevalence of this MASLD and MAS is significant. Even we are talking less about this MASLD or the MAS entity, despite having the high prevalence of this particular entity. Even in our country, we are seeing more than 30 to 35% of the overall prevalence of MASLD in general population. When it comes to the obese or overweight or diabetic population, this prevalence goes up to 60 to 80%, and that is huge. Why it is huge? Because it contributes to the other complications also. So what are the key risk factors? The primary risk factors for contributing to MASLD include the obesity and diabetes, of course, because obesity is known to be present in up to 80% of the individuals who are having MASLD or the MAS, and the presence of metabolic syndrome per se contributes to 4 to 11 times increase in the risk of development of this particular entity, which is MASLD or MAS. Although not all the individuals who are having, not all the individuals who are having obesity or type 2 diabetes or the metabolic syndrome not converted into developing NASH or the liver inflammation and liver fibrosis. So there has to be some role of genetics which we are missing, because much less is known about the genetics which are directly contributing to development of MASLD or MAS is little lesser known of, and it is under the scrutiny and under the development and under research. So some genetic factors are identified, including the PNPLA3 and TM6SF2, which are there, which we are not going into the details of. We know that the spectrum of MASLD, which is the metabolic dysfunction associated liver disease, it includes, it initiates with the accumulation of the dysfunctional adipose tissue, which is the ectopic adipose tissue excessively in the liver. So which we call as a simple steatosis without inflammation. But if it is not taken care of, then it progresses to the steatohepatitis, which involves the inflammation followed by the liver or hepatocellular injury. And then if it is again not taken care of by particular measures, including weight loss and all, then it progresses to the fibrosis. Now this is the stage of liver fibrosis, which puts you at the increased risk of development of all the complications which we talk about. A few subset of the patients who develop cirrhosis and fibrosis, they may go on to develop hepatocellular carcinoma. Even hepatocellular carcinoma can develop sometimes without the development of cirrhosis as well. But again, the patients who develop from cirrhosis to carcinoma are not huge, but because of the mortality associated with hepatocellular carcinoma is enormous, and that's why it demands for the screening of hepatocellular carcinoma in all patients with fibrosis and cirrhosis at timely intervals. Pathophysiology of MASLD, we all know that the basic forerunner, because the terminology itself, the sheer reason for the change in terminology from NAFLD to MASLD is metabolic dysfunction. So the primary reason is the insulin resistance itself. So we know that insulin resistance, it creates the lipolysis, increased availability of free fatty acids which are delivered to the liver, and then it makes the source for the de novo lipogenesis and accumulation of fat. And then this fat accumulation leads to oxidative stress, inflammatory burden, and then presence of the supportive genes for the MASLD, it creates the environment of hepatocellular injury, fibrosis, followed by cirrhosis. So this is known that from harmful lipid particles creating inflammation and this milieu. Genetic factors, I am not going into the details because we know much less about the genetics as of now, but there are certain genes which are putting the patients to the high risk of development of MASLD and MAS. The clinical presentation. So because most of the times there is no clinical presentation, there are no clinical features of development of MASLD or MAS. Majority of the patients are unaware. And that's why that is the reason that patients are not coming to us directly and we are not seeking actively for the diagnosis of MASLD or MAS because the patients are least bothered about. But we should be bothered much about this particular entity because of the associated complications. Sometimes there can be some minor symptoms of fatigue or malaise kind of things because of the spillover of the inflammatory burden from the liver to systemic circulation. And then lab abnormalities are the only things which guide us to the seeking or diagnosis of this particular entity, that is MASLD. Diagnostic criteria, how would you diagnose or label an individual is having MASLD? So name itself is suggesting, first of all, there should be a presence of documentation of fat, increased amount of steatosis in the liver by imaging, most likely with the ultrasound. Less other imaging modalities which we commonly do not go into the details, but ultrasound documentation of steatosis in the liver, presence of metabolic dysfunction in the forms of dysglycemia or hypertriglyceridemia or metabolic syndrome components, and then there should be exclusion of the excess amount of alcohol, which is the more than 21 drinks per week for men and more than 14 drinks per week for women, which we consider as a significant contributor to the alcohol-related hepatitis. So there is exclusion of significant alcohol consumption and absence of other alternative causes of cirrhosis or the fibrosis or steatosis like certain hepatotoxic medications or viral hepatitis. So these are the criteria to diagnose MASLD or MAS in an individual. Once we have considered diagnosing MASLD or MAS in an individual who is obese, overweight, or having metabolic syndrome, so first of all, we document with the use of simple imaging techniques like ultrasound, which is having a very good sensitivity to document moderate to severe hepatic steatosis. Then, once we have diagnosed steatosis, we want to see whether there is fibrosis component or not. And to measure the fibrosis, we have nowadays we can see a good availability of fibroscans across Rajkot and across all the towns also. That fibroscan not only measures the sheer amount, quantification of the fat, but also it helps in the quantification of the fibrosis which is underlying without having an invasive techniques. And then lastly, some MRI techniques, MR spectroscopy, MR elastography, which are less likely available, but they are helping in the accurately quantifying the amount of liver steatosis and fibrosis. So these are the non-invasive biomarkers which help in diagnosing and assessing or to help the knowing the progressive nature of this particular entity. Serum biomarkers, we should start with FIB4 index. Just let me tell you, FIB4 index is very easily available, which includes only 3 parameters. Age is already available to us. Most of the times the patient have the platelet counts with them, and SGOT and SGPT. So these 4 parameters, age, SGOT, SGPT, and platelet counts, you put into a simple calculative formula you will get in the Google, and you will get the score, whether the patient is having 2, 3, 1.5 or 1, between 1 to 5, whatever is the FIB4 index, and that helps you to stratify the patients who are at less risk of progression of liver disease versus those who are at high risk of progression of liver disease, and based on that we can choose further evaluation. For example, those patients who are at a moderate to high risk of progression to liver disease, then we have to consider elastography, maybe fibroscan or other ultrasound-based elastography to document or to quantify the fibrosis. And then so that we can avoid biopsy as much as possible. The goal is to avoid biopsy as much as possible, and without biopsy, if we can diagnose the proper stage of the liver dysfunction that the patient is having. So as I said, that not all the patients do require biopsy, only a few where there is diagnostic uncertainty or when there is a documentation of significant fibrosis and non-invasive test, then we go for biopsy. Now, why we do not want to ignore this particular entity? Because as I said, that is the inflammatory disease which is there in the liver, it leads to a direct increase in the cardiovascular mortality. Cardiovascular diseases are the most common cause of mortality in patients with MASLD. So the patients are not dying directly because of the liver disease. They are dying because of the cardiovascular disease if we are not treating liver properly. There is twofold increase in the cardiovascular event risk, which is independent of traditional risk factors. Even if we have managed HbA1c well, dyslipidemia well with statins, and we have controlled all other parameters since 1002, but still the unaddressed liver disease, unaddressed inflammation and fibrosis in the liver puts the patients to the 2 to 3 times increased risk of cardiovascular mortality. And the same is there with regards to the kidney disease also. It increases the kidney disease to the tune of 2-fold. That is again independent of traditional risk factors for development of diabetic and other CKD related problems. And there are other certain areas which are associated with the untreated or unaddressed MASLD or MAS, including some malignancies and osteoporosis, which are due to the increased inflammatory burden which is there for long years together. And this survival graph is clearly showing that higher degree of fibrosis puts the patient at a higher risk. So there is a direct relationship between the amount of fibrosis and the survival rate. So stage 2 and stage 3 fibrosis, stage 3 and 4 fibrosis, F3, F4, if you see, there is significant amount of mortality at the end of 10 years. So that highlights the importance of diagnosing this particular entity and treating at a proper time so that we can improve the longevity and we can improve the quality of life of these patients. So now once we have decided that this is the entity which needs attention, which needs to be addressed as a treatment, how would we treat this particular entity? Screening we have done. So the treatment, because the name itself suggested the metabolic dysfunction, so we have already speaking since morning that weight loss is going to treat majority of the metabolic syndrome parameters. So similarly in liver disease also, lifestyle modification is going to remain the cornerstone of management. So what amount of weight loss is required to reduce the fibrosis or to improve the fibrosis in liver disease? So there was a discussion in the morning that reversal of the fibrosis. So there have been clear data that if we are reducing more than 15% of the body weight loss, there are high likelihood of reversing fibrosis from F3 to F2, F2 to F1 also. Similarly, at least 7 to 10% of the body weight loss is required to show the histological improvements in the liver-related parameters. And to achieve the weight loss, we know there are dietary modifications and exercise programs which are there. So lifestyle modification is going to be the cornerstone. When we go to the medical management of fatty liver disease or the MASLD or the MAS, so again there was discussion in the previous talk that these are the 2 FDA approved molecules for the treatment of moderate to severe fibrosis in the patients with MAS, that is resmetirom and semaglutide. And then some other molecules which are still not approved but off-label use is already there with pioglitazone in diabetic patients, vitamin E in non-diabetic patients, and recently seroglitazar also. So if we just briefly go through these three, the resmetirom has become the first approved treatment for MAS which is having the moderate to severe fibrosis. Again, none of the molecule which is approved for the prevention of MAS or for early stages of steatosis only. So these are approved if there is fibrosis, not only steatosis. So resmetirom is a thyroid hormone receptor beta agonist. It stimulates the thyroid hormone receptor beta in the liver and it reduces the fatty liver and it reduces the overall hepatic steatosis and hepatic fibrosis. And there are enough data to show the reduction in the fibrosis and reduction in the LDL cholesterol level, which is less likely available in our country as of now. So that's why we are not going into the details of resmetirom. Semaglutide, which is available in our country, and recently last year, only 6 months back, it has got the FDA approval for the treatment of, again, same indication, moderate to severe hepatic fibrosis in patients with MAS, not for only steatosis. And it has shown, Essence trial is the phase 3 trial of semaglutide, which showed reduction in the fibrosis, improvement in the fibrosis, and reduction in the liver-related enzymes, and overall MAS reduction. And lastly, we have seroglitazar, which is an Indian molecule, which has been studied in metabolic dysfunction associated liver disease and some other liver disease etiologies as well, and it showed it is a dual agonist for PPAR alpha and PPAR gamma, and it has shown in some data to reduce the liver inflammation, in some data to reduce liver fibrosis also, in some cases anecdotal data showing biopsy proven fibrosis reduction. As of now, it is the only, or it has become the pioneer agent for the treatment of MAS, which has been approved by any country. It got approval by DCGI in 2020. At that time, none of the authority in the world gave approval to any of the drug for treatment of MAS or MASLD. As of now, it is under the FDA review to be approved for FDA. Right now, it is not approved by FDA, but sooner it may become approved. And some emerging therapies in clinical trials, tirzepatide, as I said, weight loss is the primary forerunner of MAS reduction. So tirzepatide has got observational data and some phase 2 trials which have shown the benefit in MAS reduction, fibrosis reduction. But large phase 3 trial is going on, so that's why it is under consideration, and some experimental molecules are also there. Lastly, bariatric surgeries are the most advanced or the highest amount of weight loss which is there with the bariatric surgeries, and they produce the significant amount of fibrosis reduction and reversal of the MAS. And if I conclude my talk, to summarize this, that MAS is the one of the major prevalent condition amongst the spectrum of metabolic syndrome, 30 to 35% prevalence. And the presence of fibrosis in the liver, it is a direct correlation with the increased cardiovascular mortality and development of CKD to the significant extent. So we should not miss this particular entity, although we have a limited amount of molecules which are directly targeting liver fat, but still we have some agents which are helpful, and we have a large number of patients which need these kind of treatments to achieve the quality of life and longevity. So with this, I would like to end here. Thank you so much. Thank you. I would like to thank Dr. Om Lakhani for teaching me the art of AI in making PPT. Of course, I have put the designing through AI, content is through real literature. Thank you.